512 subdivision C. I don't see any reasons to recuse myself, and if anyone has an objection to my presiding over this matter, I will entertain that at this time. Mr. Spackman?
No objection.
Ms. Alvarez?
No objection, Your Honor.
Thank you. With that, then, the time constraints are as follows. Mr. Spackman, you will go first with 15 minutes. Ms. Alvarez, you will go next with 15 minutes, and then you'll each have 5 minutes of reply. Mr. Spackman, go ahead.
All right. First of all, Dr. Corral is not here today. She's actually in the hotel upstairs, but she became violently ill last night and just cannot be down here, although she definitely wanted to be here to answer any questions you might have. I'll try to go through this fairly quickly. I don't know if I'll be able to get through all my notes in 15 minutes. I might have to go over and use some of my reply time. Appreciate the opportunity to be here. I'm hoping that after you hear more about the case, you will be inclined to either reduce the discipline to a public letter reprimand in the record-keeping course or to dismiss the accusation altogether. But PD recommended 2 years probation in the medical record-keeping course. And the reason I think you should be doing this is because the basis for discipline in the PD is not supported by clear and convincing evidence, and because there are legal and factual errors, very significant legal and factual errors in the proposed decision. Further, there are mitigating and rehabilitative factors, which include this is a very unique patient case, as you find out, as you probably know by looking over the PD. It occurred 7 years ago. Dr. Corral has an excellent reputation among her Kaiser patients and colleagues, which is also noted in my brief and also in the proposed decision. And also her acknowledgement at the time of the hearing, today, if she were here, of the medical legal necessity of taking even more comprehensive and robust medical records, especially in the era of Kaiser's electronic medical records. Also, I should mention that she was just recertified in family practice within the last year. Now, just very quickly, just for background for the case, so you get an overview. On June 12, 2005, a 47-year-old male lawyer was seen at Kaiser for low back pain and leg pain of 6 to 7 weeks duration. He was examined and treated with Flexeril and muscle relaxant, Relafin, a NSAID for pain. On June 26th, he was seen by his regular doctor for what had become severe pain. He was examined, x-rays were taken, and that doctor at that time, it's not mentioned in the proposed decision, quadrupled the amount of Relafin that the patient was being given for pain. At the same time, he prescribed vitamin ES, 40 tablets to be taken every 4 hours as needed for pain, 1 tablet. There's a mistake in the proposed decision where it mentions that he was only prescribed 30 tablets as opposed to 40 tablets. As you'll find out, that's quite significant, where the case in large measure is hinged on arithmetic to reach a determination that the patient wasn't taking enough pills to be opioid tolerant. On August 2nd, his pain was worse. He was seen again, this time in the emergency room. The patient said Vicodin wasn't helping. The doctor prescribed 30 oxycodone per step to be taken 1 or 2 every 6 hours as needed. This is documented in a progress note and also in the pharmacy record. The doctor ordered an MRI. 2 days later, he came in. He wasn't sane, but he came into the pharmacy requesting that a refill on his pain prescription. Presumably, that was the Vicodin, and that he had just been prescribed the Percocet a day and a half before. And it's unlikely he would have taken 30 pills in a day and a half, so he had to walk in. On August 5th, just a little bit after midnight, he came into the emergency department. He said he'd taken all the Percocet that he'd been prescribed on August 2nd. His pain was worsening. What's not mentioned in the proposed decision is that the patient had multiple issues other than pain management. They ruled out an embolus in his leg. He had urinary retention, hypertension. They ruled out quadriplegia syndrome. He had elevated liver function tests. He had elevated white blood count. He had elevated cholesterol. He was referred at that point to neurosurgery, which is documented in the chart. And he was given more Vicodin, even though the directions were that he was supposed to see the patient Dr. Krause did see the patient 4 hours after he was discharged from the emergency room. I transcribed your note, which is on page 6 of the written argument, so you don't have to read her handwriting. She reviewed the chart, including the pharmacy record and the emergency department record before she saw the patient. She testified that the patient was very frustrated. He was in a lot of pain. He was angry. He threatened to sue Kaiser because he didn't feel that he was being worked out quickly enough. Dr. Corral also noticed in the emergency department note that he'd taken off Percocet in 2 days. She noted that morphine caused vomiting and that the patient was requesting patches. She testified that the patient said he'd been given a fentanyl patch before and that it was effective. She documented his history of low back pain. She mentioned that he had a MRI pending and that he had one that day outside Kaiser, which showed herniated discs, that the ultrasound was negative for thrombosis, and on physical exam she noted he had edema. She also mentioned that in her note that he had elevated liver function tests, he had a history of alcohol consumption, family history of cardiac disease. And her plan was to do additional tests and to give the patient a trial of Duragesic patches between 50 and 75 micrograms per hour to be taken every 3 days and to follow up with his primary care physician in 3 weeks. And this is important, I'll go into this later, but the follow-up was to be for a physical examination based on all the problems he has had and all the risk factors that he had, and to also check the laboratory tests that Dr. Krell ordered that day. We know that subsequent to that, the next day, the patient was taken to the emergency department and could not be resuscitated. According to the autopsy report, that his death was from natural causes, that he had dilated cardiomyopathy, and that toxicology showed that he had fentanyl in therapeutic level for an opioid-tolerant person. Now, the adverse findings in the proposed decision. The first one is that it was gross negligence for Dr. Krell to prescribe Duragesic without documenting the patient's prior opiate use. Dr. Sir testified that it was an extreme departure. She testified that she couldn't tell if the patient was or wasn't opioid tolerant based on Dr. Corral's note. She also testified that when she looked at the entire record, which would include the pharmacy record, that she could tell why the patient had been prescribed opiate, what opiate, the quantities that the patient had taken, all of the Vicodin between the 26th and August 2nd when he was prescribed for Percocet, that he had been prescribed 30 Percocet on the 5th, and that he had, on the 2nd, and that he had taken all of those by the 5th. I'd also argue that her testimony should be disregarded. She testified that in her entire career, she had only once initiated a prescription for a fentanyl patch. Dr. Schlosser was a pain management expert who testified for the board. He testified that based on his review of the record, the patient was not opioid tolerant. So we obviously have a conflict in the experts. One, Dr. Sir saying, I can't tell, based on Dr. Corral's note, and Dr. Schlosser saying, I can tell. And according to this, my opinion is that the patient was not opioid tolerant. So you can't have it both ways. They can't both be right in this case, but they also can both be wrong. Dr. Schlosser, further in his testimony, was unclear as to whether this was a departure, whether it was a simple departure, whether it was an extreme departure, as far as the documentation is concerned. He said that the patient's prior opioid use was not sufficient for there to be a 50 microgram per hour patch. But he also, in his report, said that it wasn't unreasonable for Dr. Krell to prescribe that amount because the patient had been taking so much Percocet in the previous 2 days. Dr. Berger was the pain management expert for Dr. Corral, and Dr. Berger is not a psychiatrist who's practicing pain management on the side. He started the pain management program at USC School of Medicine, and he oversaw all the pain management in all of USC's three hospitals from 2000 to 2005. He testified that Dr. Corral did exactly what would be appropriate for a pain management specialist. And he said that the 50 microgram per hour patch was appropriate. Dr. Sahlberg, a primary care doctor, who unlike Dr. Stewart does use Duragesic patches for his patients, agreed with Dr. Berger. So in short, on this, there's insufficient evidence to support this charge. A related but more troubling finding is Judge Johnson's finding that this patient was not opioid tolerant and that it was gross negligence to prescribe it. This, first of all, raises a legal issue, which I mentioned in my brief, and that is whether the package insert, such as you have in the physician's desk reference, establishes the standard of care. This issue was resolved in a case that I cited on page 21. It's the Slagel case. And in that case, a patient sued Stanford doctors, saying that they used an improper amount of contrast material. And that what they used was different from what was in the manufacturer's package insert. The court held quite clearly that the package inserts, such as you have in the PDR, do not establish the standard of care. So what the problem here is that the PD is legally erroneous. In finding of fact 13, Judge Johnson writes that uses the word standard of care. She says the standard of care requires, and that's followed by a verbatim recitation of what's in the black box warning for Duragesic in the PDR. And that is that opioid tolerance is established by a patient taking 60 milligrams of hydrocodone or 30 milligrams of oxycodone daily for longer than a week. Further, in finding 14, she found that the patient was not opioid tolerant because even though he'd taken more than the amount of Percocet, during the 5 days prior to that, the patient was only taking 30 milligrams, half the amount of the oxycodone. And that as a result, it was gross negligence. So here we have a factual problem as well, because she was using that the patient was taking 30 Vicodin when he was actually taking 40 Vicodin, they prescribed 40. And so instead of taking 30 milligrams a day, here that was actually, according to Dr. Strasser, taking 43 milligrams a day. So he's up over 60% of what the PDR guidelines would be, yet we have a finding of gross negligence and apparently no room for clinical judgment. The other problem is that Dr. Strasser averaged the hydrocodone and Percocet to arrive at his figure, and he averaged them separately. When you average them together over the 9-day period that the patient was being taken them, you end up, according to Dr. Sahlberg, with 67 milligrams, which is well over what the PDR has as a baseline. And according to Dr. Strasser, that was Dr. Sahlberg before, according to Dr. Strasser, using his conversion rate, you would end up with 57 milligrams. So in other words, we're talking about a finding of gross negligence where, even according to the board's expert, we're 3 milligrams short. We have 95% of what even the package insert requires. So I don't think that this finding can stand either. Now there's another problem with this finding, and that is that we have guidelines for the PDR, and then you also have a testimony by all the doctors that the best person to tell you how many pills they're taking is the patient. Dr. Corral spoke with the pain management doctor. He said this patient's got to be taking 8 pills a day for 7 days, whether it's Vicodin or whether it's hydrocodone. She talks to the patient, she points to the calendar, and she said, have you been taking, for the last 7 days, 8 pills a day? And the patient said, yes, he had. So she instead of doing this averaging, which had already been done by the pain management doctor, she was finding out directly from the patient that he was taking the number of pills. And one of the problems with the proposed decision is that Judge Johnson finds that there's a discrepancy here, because the patient was only prescribed 40 pills, And if he had been taking 8 a day during the entire period from when he was prescribed it until when he was out of it, it would be 56 pills. So she's basically saying, no, it's arithmetically impossible. But the problem is, and I pointed this out in my brief, she's basically saying that he hadn't been taking the hydrocodone for 7 days and the Percocet for 2 days. And Dr. Corral, 7 different times during her testimony, said no, it was 4.5 to 5 days of the hydrocodone and 2 days of the Percocet for a total of 7 days. It wasn't 7 and 2. And when she did the math, the 40 was fine. It meant that the patient for 5 days was taking 8 pills. The implication is that he didn't start taking them right away. And there's a good reason to think that he wasn't. Number one, the Relafin had been quadrupled when he was given the vitamin prescription to be taken as needed. And number two, that made sense to her and also to our experts as a practicing physician that as patients' pain increases, they ramp up their pain medications, which is entirely consistent with what we have here. So factually, just finding that the patient was an opioid tolerant can't stand. With respect to follow-up, that finding isn't supported by even the board's expert, Dr. Strasser, who found that it was a simple departure for the patient not to follow up within a week with the patient. Dr. Sir did not find a departure in this. She was asked to look at everything, to say what the criticisms were. She had no criticism of the follow-up. Dr. Stolberg and Dr. Berger said there is no departure. What happened here is that the reason, Dr. Corral's reasons for not seeing the patient personally within 3 days is that the patient told her he couldn't do it. He was going out of town. She wanted to have him come back in. But what was in the chart is that the patient had that morning been referred to neurosurgery. And when she spoke with the patient said that he had the MRI scheduled and that his wife right then was on the phone talking to neurosurgery to get an appointment for him that week. So, if Dr. Strasser testifies that the standard of care is a follow-up within a week, this patient was going to be followed up within a week. And when the neurosurgeon sees the patient to determine whether he's a surgical candidate or not, according to Dr. Corral, he also would have addressed his medication management and how he was doing with music. The other problem here is that the fact that the patient died the next day made it sort of impossible for Dr. Corral to follow up on the patient. She testified that she called the patient's home early in the week. She saw the patient on a Friday. She called her earlier in the week and then found out that unfortunately the patient had died. The final issue here is the medical record keeping. And I might have to bring this up later if I run out of time, but I'll get started on it. Okay. And first of all, the proposed decision says that Dr. Corral did not keep adequate and accurate records. Now, this may be a technical issue, which needs to be straightened out, but she also did not find that there's a violation of Business and Professions Code 2266. Instead, she said that it was the medical record keeper was negligent by Dr. Corral. And there were 3 specific areas where she felt that the record keeping was below the standard of care. One, she said, was to not document the patient's prior use of Vicodin and Percocet. If you look at the entire medical record, those are documented. They're in a pharmacy record, they're in the progress notes, it's in the emergency department record before Dr. Corral sees the patient. Dr. Corral mentions that the patient's current medication is Vicodin and it's not helping. And then that very morning, 4 hours before, we have a reference to the patient being given the 30 Percocet and taking them all between August 2nd and August 5th. So that information is there, and the issue becomes whether it's a standard of care for a physician to recapitulate everything that's in the patient's medical record and write a Bible each time you see the patient, or whether where it's in the medical record in very close proximity to when the doctor sees the patient, that's sufficient. The other issue that was raised with respect to the medical record keeping was a criticism that Dr. Corral didn't document how the patient was to take the Duragesic patches. As I mentioned it in her note, she says 50 to 75 micrograms per hour for the patch. When she met with the patient, she prescribed the 50 milligram patch and the 25 patch, told the patient to try the 50 patch and then come back in 3 days and see her, and they evaluate whether it was having side effects, whether it was effective. The patient said he couldn't do it, he was going out of town, and he wanted something as a backup. So it was that point in time that she prescribed the 50 and a second prescription for a 25 patch, and told the patient to wait 6 days before he used the 25 microgram per hour patch in addition to the 50 microgram patch. She testified that she hand wrote his instructions out and handed it to the patient at the time of his visit. The patient also was instructed on the use of the Duragesic and risks, things to watch out for when he received the medication at the pharmacy. He was also given a handout at that point in time.
Council, it's 15 minutes. I'm going to stop there. Ms. Alvarez?
Thank you. Good morning. The primary problem in respondent's case, not only in her argument, but also that was very evident in trial, is that both respondent and her experts based their opinions on assumptions and speculations. The main assumption or speculation is regarding how many Vicodins this patient actually had really taken prior to the August 5, 2005 visit. Respondent and her experts all had to speculate because respondent failed to document the critical factors in deciding whether to prescribe this Duragesic patch to the patient. And all the experts in this case all concurred that this patch is a dangerous drug and can cause death. Respondent contends that the medical record sufficiently documents the patient's prior opiate use. However, nowhere in the medical records, including the pharmacy log, does it detail the amount of Vicodin that this patient was taking. The only place that we get this is from respondent's testimony, which is has a discrepancy into actually what is in the medical records. The pharmacy log contains one prescription for Vicodin, and that was for 40 pills, and it was prescribed July 26th. Respondent claims to testify, because it's not in the record, that on August 5th, when the patient came to see her, he told her that he was taking 8 Vicodins daily for at least 5 days of the 7 days prior to that visit. So 7 days from August 5th prior. Respondent testified that she reviewed the pharmacy record, the log, so she was aware that there was only one prescription for those 40 pills. She admitted in her testimony that there was a discrepancy between the patient's July 26th prescription of only 40 pills and the patient's alleged statement that he had taken 8 pills of Vicodin for 5 to 7 days prior to the August 5th visit. She did not document any of her discussion regarding his Vicodin use in her document or her medical record. How could she possibly determine if the patient was opioid tolerant with this discrepancy? She couldn't. What should have happened is she should have asked him about this discrepancy and asked him where he could have possibly gotten the other Vicodin. Respondent testified that she spoke to a pain management specialist. The pain management specialist allegedly asked respondent to verify that the patient had been taking 60 milligrams per day of Vicodin and 30 milligrams of the Percocet for at least 2 days for a total of 7 days in order to establish that the patient was opioid tolerant. She did not document the discussion with the pain management specialist, nor did she remember his name. Again, there's a discrepancy in what the pharmacy record says and what the medical record has and what respondent testified to at trial. The patient only had 40 pills of the prescription Vicodin, and that was again only on July 26th. 7 days later, he goes to the ER room on August 2nd, and that's where he was prescribed 30 Percocet. That was at 5:15 p.m. on August 2nd. He was given 30 pills at that visit. So between July 26th and August 2nd, there were 7 days. respondent and her experts want us to believe, to assume, or to speculate that patient waited to take his Vicodin instead of starting on the 22nd of July. That's not believable. This is a person who is in severe pain. He is not going to be waiting to take his Vicodin. Here, the patient presented to his primary care physician on the 26th of July with severe pain. It's documented in the medical record. And he stated that his pain was not relieved by the Flexerol or by the Relapharin. He's also given Percocet, and he takes all of it, 30 tablets, in 3.5 days, not 2 days, as respondent experts keep stating. But respondent experts want us to assume or to speculate that he didn't take the Vicodin starting on July 26th. That does not make sense. Respondent testified that the patient would not necessarily start taking the Vicodin after he saw his primary physician on the 26th, since the patient may, we have to assume this, may have wanted to see if the other drugs would start working. Again, she's speculating. She never asked the patient. As such, respondent's contention that the medical record sufficiently documents the patient's prior opioid use is wrong. Respondent also contends that the patient was opioid tolerant under any methodology. She argues that Dr. Sir and Dr. Strasser, the complainant's experts, were inconsistent with each other. This is not true. Dr. Sir opined that the respondent should have documented whether the patient was, 1, opioid tolerant, and 2, how she determined the patch dosage. She testified that from the respondent's medical records, she could not determine whether the patient was opioid tolerant. This is true. The medical record, that the note that Dr. Corral actually noted, does not have anything that would allow a person to determine whether this patient was opioid tolerant. Dr. Strasser did not testify that there was sufficient documentation in the record to make this determination. Respondent argued that Dr. Strasser was able to determine the daily opiate dosage based on the same records by averaging the medications. This is a misstatement of Dr. Strasser's testimony. In volume 1, page 101 of the reporter's transcript, lines 15 to 25, Dr. Strasser was asked, when determining whether Mr. S was opioid tolerant, didn't in fact you have to assume the quantity he was taking, because it's not anywhere in the record how much he was taking daily? His answer, I had to make an estimate of his daily consumption because it was not reflected in the medical record. And the estimate that I chose to make was an average, based on my understanding of the amount of medication he had been prescribed. Respondent's expert, Dr. Salberg, testified that he was able to tell how much opioid medication the patient had been taking just by looking at the entire record. He discounted the discrepancy of the amount of Vicodin, the one prescription, and then once again assumed that the patient probably started taking the Vicodin after July 26th. Dr. Salberg also incorrectly assumed that the patient had taken the Percocet in a little over a 2-day period. This is incorrect. The patient presented to the ER on August 2nd at 5:15, and he didn't present to the emergency room again until August 5th at a little bit after midnight, around 12:30. That's 3.5 days, not 2. The patient, Dr. Salberg speculated again that the patient did not take the same daily amount of Vicodin during the 7 days. Again, this is an assumption because respondent did not ask the patient. Respondent's expert, Dr. Berger, discounted the use of Vicodin completely and testified that the patient's use of the 30 Percocet in 2 days demonstrated that the patient was opioid tolerant. He calculated that the Percocet was equivalent to 67 milligrams of oxycodone and the 50 microgram patch was appropriate. Again, the patient was prescribed the Percocet took the Percocet 3.5 days prior to August 5th. So the conversion was actually closer to 42 milligrams of oxycodone. He was wrong in his conversion. Both of respondents' experts were very argumentative and did not concede any hypotheticals. In fact, Judge Johnson specifically found that Dr. Salberg and Berger appeared to be biased and to advocate on respondents' behalf. She also found that Dr. Berger did not know the definitions of the standard of care. Respondent also failed to address the fact that both of the prescriptions she wrote for the patient were incorrect. She wrote a prescription for the Duragesic patch for the 50 for 50 milligrams, which is a lethal dose. It does not come in that dosage because it can kill a person instantly. On the 25 microgram patch, she wrote, again, milligrams, which again would be lethal. And she also wrote on that prescription that the patient may combine the 50 milligram patch as needed with the 25. This belies her contention that she gave the patient specific instructions to wait 6 days before using the 50 microgram patch, and only when the 50 microgram patch worked and he had no side effects did he add the 25 microgram patch. And again, these specific instructions weren't documented in her medical record or anywhere in the entire medical record. She also indicated on those 2 prescriptions that this Duragesic patch could be refilled. This is a prescription that cannot be refilled. Based on what's in the medical record, an actual determination, not based on assumptions or speculations, could be made whether the patient was really opioid tolerant. Respondent contends that the follow-up was appropriate under the circumstances. She testified that she knew that the patient was going to see a neurosurgeon in a week, and that she planned that the neurosurgeon would assess the patient's response. Again, this is not documented anywhere. The only indication of the follow-up was a notation saying follow-up in 3 weeks. Dr. Strasser did testify that it was reasonable to follow up within 3 days. 3 to 7 days, not 3 weeks. Again, the respondent wants us to assume that she wanted the neurosurgeon to do the assessment. How would we know this? It's not documented. How would the neurosurgeon know this? It's not documented anywhere. Respondent contends that the consultation with the pharmacist and the pain management specialist was not necessary to be documented because they were curbside consults. This is not true. She testified that pain management specialist was the actual physician who determined whether the patient was opioid tolerant and what the dosage should be. Dr. Strasser specifically testified, quote, essentially, she was advocating responsibility for making the dose conversion to herself to those other clinicians. So if needed, she was placing so much reliance upon their opinions, and it should have been documented in her notes to clarify her thought processes. Because ultimately, it's the physician's, it's the responsibility of the physician who prescribes the medicine to prescribe the appropriate dose and the safe dose, and in this case, that was not done. Her discussions with the pharmacist and the pain management were critical in her decision making. In fact, the pain management specialist is actually the one who did it. It should have been documented. These were not curbside consults. This was actually the actual decision making process of the physician of what the patient should have received. In regards to penalty, the proposed decision does not comport with the disciplinary guidelines. At trial, it was requested that there be a revocation stay, 5-year probation period. Again, I would request that, along with not only medical records, but an actual prescribing course. Thank you.
Thank you. Sir, you have 5 minutes.
Okay, just to clear up a couple of things. One is that the patient was taking Percocet for 3 days. Well, that would be fine if that were the case, because that would even give more force to the appropriateness of Dr. Corral's prescription. But the record in the testimony is quite clear that the patient was seen around midnight on the 5th, so that would be 57 hours from 5 p.m. on the 2nd. So the patient was taking the Percocet for 2.25 days, not 3.25 days. The other thing is, she mentioned the testimony of the experts. And this is a problem that we have sometimes, and we see these in proposed decisions where the respondents, when respondents have forceful witnesses, they're described as being biased. They were forceful witnesses, especially Dr. Solberg, who was forceful, but he was also analytical. With respect to Dr. Berger, he did definitely know the definition of simple negligence, which is what a prudent physician would do under the same or similar circumstances. And he said that there is no departure from the standard of care. Both of these doctors were shocked by this case, where it basically stands for the proposition that doctors are supposed to be practicing cookbook medicine, where we use guidelines in the physician's desk reference, which are package inserts by the manufacturers, as some sort of a Bible which doctors have to adhere to. They both testified that yes, this is an important consideration when you do any prescribing, but at the same time, you also exercise clinical judgment. And in this case, this patient was so greatly exceeding the amount that he needed to take during those 2.25 days when he was taking twice the amount of Percocet that he needed to take, that in their mind, that combined with the Vicodin made it very obvious that this guy definitely was opioid tolerant and able to take the dose of fentanyl patch that Dr. Corral prescribed. Now, there's also an argument by complainant that our experts were speculative. But, where are you going to decide this case? You're going to decide the case on the basis of failed second-grade arithmetic, which is what you'd have to do if you go along with this proposed decision? Or are you going to decide it from the proposition that physicians consider guidelines and that they also exercise their clinical judgment, and they also make certain assumptions when they see patients? And one of those assumptions, which from a common sense standpoint seems to be irrefutable, is that patients take more pain medication as their pain increases. So it's entirely consistent that this patient didn't start taking Vicodin, didn't start taking Vicodin in very large doses when he saw the patient on the 26th, but instead he started taking more later on. So there are two ways you can do this if you're not averaging. One is you start at the beginning, which would be the 26th, and you try to figure out, well, what did the patient not take them during those first 2 days? Or you do what Dr. Corral did, you go backwards, which makes more sense because patients are not going to keep the track. Oh, I took 5 pills on the 27th, I took 3 pills on the 28th. But instead you work from when you see the patient during that visit. This is what our experts testified to, and that's then you go backwards for a week and determine if the patient is opioid tolerant or not. Now, the other point with respect to the follow-up, and that is that unfortunately Dr. Corral didn't document her discussions with the pharmacist and with the pain management specialist. Now, with respect to the pharmacist, testimony by Dr. Corral and also by other people is that doctors call pharmacists all the time when they ask for advice about medications, when they ask for conversions. And in this case, the PDR did not have a way to convert the hydrocodone to oral morphine, so she couldn't do it. So she called the pharmacist to find out what the conversion ratio would be. He told her that it would be appropriate to use 50 to 75 micrograms per hour. She didn't document that because this is something that's commonplace in her practice to be calling pharmacists. He's not seeing the patients, he's not treating the patients, she is. The same can be said with respect to the pain management physician. Obviously, it would be great, and we probably wouldn't be here today, if Dr. Corral had written something like, in quotes, D/W, Dr. Smith. Put that in her note, made it obvious that she talked to someone. She didn't do that. And the reason she didn't do it is because she considered it to be a curbside consult. This doctor wasn't taking over the patient's care. He wasn't seeing the patient. It wasn't a formal consult. He wasn't doing any sort of dictation. Instead, she just called him and asked him for advice. He asked her lots of questions about the patient, what he'd been taking, for how long, questions about his alcohol, whether he was having any side effects. And on the basis of that, and also her visit with the patient, her clinical assessment of the patient, who she thought seemed very intelligent, very reasonable, she went ahead and wrote her prescription for the patient. She was the one who was providing the treatment, not the pain management doctor. It was her prescription. She wrote the prescription out. She wrote milligrams instead of micrograms because this isn't a medication that she's familiar with. Obviously, a pharmacist couldn't fill something like that. That was many multiple times of what a pharmacy has in stock. We argue that we have a 2-year probationary period recommended by Judge Johnson, and that's excessive. It's excessive because, number one, the legal error that we have basically saying that a physician desk reference is the standard of care. That's in this decision, that can't stand. Number two, that finding, for the reasons that I described before, is faulty. Second, with respect to the opioid tolerance issue, as I mentioned before, Dr. Strasser testified that this patient was not opioid tolerant, but now complainant is saying that, well, you know, he had to average to do that. Well, that was an appropriate way to do it, and that's probably how a lot of physicians would do it. And even when he uses averaging, the proposed decision is entirely off. It's not 30 micrograms a day of the hydrocodone, it's 43. If you average them together, according to even Dr. Strasser, it's 57. If you use Dr. Solberg's, it's 67. Plus the patient is taking all the Percocet. So factually, the finding that the patient was opioid tolerant shouldn't stand. With respect to the follow-up, that also shouldn't stand. It's documented that the patient was referred to neurosurgery, and that was documented 4 hours before when Dr. Corral saw the patient, so she didn't see any reason to repeat that in her note. Finally, and I don't want to harp on this too much with respect to the discrepancy, Dr. Corral did not testify that there was a discrepancy. She was asked whether there could be a discrepancy, and testimony was there could be a discrepancy if you're using the 7 days, but then 7 different times, and I have some of the quotes in my written argument, she made it crystal clear there is no discrepancy. If the patient had a prescription for 40 pills, he only had to take 8 a day for 5 days, even 4.5 days. So there isn't a problem with the arithmetic. There isn't a discrepancy. What happened is that the patient simply started taking medications in higher quantity as his pain increased. So again, we ask that we have a rewritten proposed decision that comports with the law and the facts, and that at most a public letter of reprimand with a recommendation or an order that Dr. Corral take a medical record, keep in course the maximum penalty here.
Thank you, Councilor Butcher.
Thank you. In regards to the discrepancy, there is discrepancy. He was given one prescription. I hate to harp on this, but there was, and this is what happened at the trial. There was one prescription that was done July 26th. 9 days later, August 5th, it said that it was assumed that he didn't start taking his medication until a later time, not July 26th. It was never asked of him. It was an impossibility. There was only 40 pills. If he had taken it starting at July 26th, he would have had to have 56 pills. So yes, there is a discrepancy, and it should have been asked. And regarding that there was no finding that there was a failure to maintain adequate records, there was. Legal conclusion number 6 of the proposed decision does contain language that respondent did fail to maintain adequate and accurate medical records for part of this patient's care and treatment. In regards to Dr. Strasser being a psychiatrist who on the side practices pain management, that's not correct. Majority of his patients are pain management patients. A small part of his patient population are psychiatric patients. And I submit that, again, that this is a case that's based on assumptions, and it should have been based on assumptions. It could have been clearly established whether this patient really was opioid tolerant. The prescriptions could have been correctly done, especially if the respondent did not want him to combine the 25 microgram with the 50. It should have been specifically put on the prescription, and it wasn't. It was stated as needed. That's belies her contention that she was very specific in her instructions. I submit that the disciplinary penalty is not important with the disciplinary guidelines, and I again request that, in the very least, that the respondent also be requested to do a prescribing course. And if you can, I'll have any questions.
Thank you. If you have any questions, and I caution them again, that we cannot solicit new information, but you can ask for clarification of the evidence. So I'll start with my right, sir.
I don't know if I can ask this. You can tell me.
If you can just for the court record identify who you are.
I'm Dr. Bishop. Why were the pharmacist and pain expert never deposed?
We don't take depositions in these, or the board.
But I just see they were not, neither one was on the witness list. I saw no testimony from either of them.
I can answer that.
Is that, I don't possibly do that now.
It was part of the deposition. She was deposed in the respondent was deposed in a civil matter. She could not remember the name of the pharmacist or the pain management specialist.
Actually, if I can answer that, I think in her deposition, she remembered the first name of the pharmacist, but she didn't remember the name of the pain management person. And but we have to realize that the deposition occurred quite a long time after the patient was treated.
I asked the additional. It was asked at the trial whether she tried to contact after the patient passed away, whether she tried to contact the pain management specialist, and she said no, she didn't remember.
And to add to that, the reason that she didn't do that is because it was her understanding that the patient's demise was unrelated to the prescription, which is reinforced by the coroner's report.
I do have a question, Barbara Yaroslavsky. Is this being a Kaiser situation, a Kaiser case, at all an issue, given that there's internal medical records that are totally always shared and collaborative? I mean, it seems like I was just wanting to make sure that I shouldn't be concerned that this is a situation by which, in this situation, there was no discussions that seemed to be going on between the previous medical personnel, the current medical personnel, and the future.
Well, I'm not sure.
So that the pharmacist was asked questions.
Yes.
The medical records are there. Kaiser has a shared records and shared everything. That should I be at all concerned that this is?
Well, I can probably cover this one way, and that is whether you should be concerned with respect to today. But what happened is this case was in 2005. At that point in time, a lot of the records were computer accessible. For example, the pharmacy record would be available to anybody. Dictations and things like that would be available. They scanned the emergency department record, so that was available to Dr. Crow. But in 2006, what happened at this particular Kaiser service area is that they switched over to the electronic medical records, so that now
So
there's
this was
much more
before
complete information available. Yes.
Okay, that's what I didn't.
Okay, so she did testify that she had the pharmacy log and the emergency room department, and then the prior progress reports from the other primary care physicians.
Okay, thank you. I have just one question, Sylvia Diego. Did you say that the patient said that he wanted to reduce the patches?
Yes. Yes, that's documented in Dr. Carell's note that the patient was requesting patches, and she underlined
Because he had
patches in the
used
note
them
as well. Yes.
Your final question, because he had used them before?
Yeah. Well, she didn't put that in her note that he had used it before. The only thing she put in was the quote requesting patches. She discussed the patient's prior use of the patches, and her testimony was that he had used them before for a kidney surgery problem that he had, and that it had been effective.
One more question related to that, Dr. Bishop again. Did anyone check for pharmacy records or prescription records of that Duragine patch used in the past?
No, they did not. Well, actually, let me explain that. I don't before.
Wait, was that evidence at the hearing?
No.
One way or the other?
It wasn't. But let me correct myself when I said they did not. I don't really know because that didn't come up.
Sorry.
That's totally fine, sir. Anything further? Okay, thank you. We're going to go to closed session. I've asked everyone to please leave the room. Thank you.
Okay, ready? On the record? Thank you very much for your patience. And I'm going to turn it over to our administrative law judge.
Thank you. On the record, in case number 17-2007, 183005, OEH number 2010, 011001, this matter is on a remand from the Superior Court for reconsideration of the penalty in that matter. May I have appearances, please, beginning with the respondent's counsel.
Paul Spackman of Buick and Spackman. I'm here representing Dr. Donald Lee.
Good morning, Your Honor, and members of the panel. E.A. Jones III, Deputy Attorney General, Supervising Deputy Attorney General, here on behalf of the President.
Thank you. And as I've disclosed in the other cases, I was formerly a prosecutor with the Department of the Attorney General's office in the H3 section. The medical board is one of my clients, but I know nothing about this case, and I find no grounds under Government Code 11425.40 or 11512 subdivision C to recuse myself. If either party would like me not to be the hearing officer, I'll entertain that motion at that time. Mr. Spackman?
Objection.
Mr. Jones?
Objection.
Thank you. Before we begin, this matter and another matter, case number 09-2010, 205-998, OAH number 2011-120070. Dr. Lee has just entered into a stipulated settlement with the board effective November 2nd, 2012, which puts him on probation for 6 years with terms and conditions, and the board members can take official notice of that since it is their decision. I will pass it down to the board members to consider. The way this will work is, Mr. Spackman, you will have 15 minutes, and sir, you will have 15, and you will each have 5. Mr. Spackman?
Good morning. Dr. Lee is not here today. It's somewhat embarrassing because I always tell these physicians that it's really important for them to be here and be seen in the flesh. And for the prior case, we have a doctor who is here but violently ill. And in this case, Dr. Lee is not here. And the reason being, and it's also reflected in the transcript, is that he's on a medical mission. At the hearing, he testifies that he does this about 4 to 6 weeks of the year. And unfortunately, we didn't have a lot of notice with respect to this being put on calendar, and he had already headed and organized a trip to Cambodia with a number of other healthcare practitioners, and he left this morning, and that did not be changed. But anyway, this case is not as complicated as some other cases. We have a board decision that was remanded by Judge Kinney of the Sacramento Superior Court, where Dr. Lee was put on 5 years probation and required to take a medical record keeping and an ethics course. And as Judge Matuszewski just mentioned, there's a subsequent case which was settled by stipulation. I was not involved in that case in any respect. I didn't really learn about it until after the stipulation was entered. So I guess you'd say we have 2 issues here. One is, what do we do to have a decision that comports with the findings of Judge Kinney? And then independently of that, I suppose, is what happens with respect to the penalty. In other words, does the subsequent one essentially moot out the issue of the penalty, or is there some concerns that we nonetheless need to consider in this case, or do they dovetail somehow? But I'll discuss that in a minute. But I think ultimately the result here should be that the penalty is lessened. As I mentioned in my brief, we're kind of upped it with that concept, let the punishment fit the crime. I know these are civil proceedings, administrative hearings are, but nonetheless it makes eminent sense that if the vast majority of the findings, and really all the serious findings, have been thrown out, that the penalty should be reduced in order to comply with the Superior Court judgment. And that's said despite the fact that the board has substantial discretion under the law when it comes to penalty. that being said, we can't ignore that a Sacramento Superior Court judge exercising his independent judgment decided that many of the bases for discipline were not sustained. We have two patient cases here. They date from 2007, 2008. One of them had to do with a woman who had a hip fracture, and the findings by Judge Capizone on that were that it was negligent for Dr. Lee not to have done something similar with respect to the patient's hip fracture. It's a bit confusing facts because there's a negative X-ray. But probably more important is there are findings, and all these findings were stricken, by the way, that Dr. Lee was grossly negligent, that he was dishonest, that he fraudulently altered the patient's medical record by adding information to a patient visit, and that he engaged in unprofessional conduct. None of these were sustained. The only thing that was sustained with respect to this patient case were deficiencies in Dr. Lee's medical record keeping. So this was an outpatient, and probably the principal finding with respect to his medical record keeping on this patient is that some of the patient visits, and again there were lots of visits because he saw this patient as her primary care physician, her internist, for quite a few years. So there were dozens of visits. But in some of those visits, Dr. Lee's medical assistant wrote down that the patient didn't have any drug allergies. And apparently Dr. Lee didn't catch that, or that he didn't change it. There's no issue that this resulted in any harm to the patient. With respect to the other case, it involves the hospitalization of an elderly patient, and Dr. Lee was the patient's primary care physician, and he was also the doctor who managed the patient's care during the hospital. In that case, the Superior Court did sustain findings of negligence, and basically the crux of this case is that the patient fell down. He fractured a rib, which was shown on X-ray. Dr. Lee admitted the patient for observation. And at 2:15, Dr. Lee wrote a note that says, quote, DC home with O2. In other words, discharge home with oxygen. This was on a Friday afternoon. At that time that Dr. Lee wrote that discharge home with O2, the patient's vitals were not okay for that discharge order to be written. And Dr. Lee acknowledged that at the hearing. In fact, the patient was even on a non-rebreather mask at the time as opposed to a nasal cannula. What he testified he intended by that order was that the patient be discharged that day, but that arrangements be made for home oxygen to be delivered to the patient's home, so that when he did go home later in the day, everything would be in place. This was a small hospital, and he said it was a Friday afternoon, and if that wasn't put in place, the patient would have had to have stayed at the hospital over the weekend, which the patient did not want to do because the oxygen machine would not be available at his home to get him through the weekend, or tanks or what have you. What happened subsequent is that the patient was discharged, actually sent home. I mean, technically, I don't know, there's a problem here with respect to who's responsible and how. One can say that Dr. Lee is ultimately responsible because he wrote DC home with O2. But what happened is that the patient was seen subsequent in the day by a member of Dr. Lee's group. Dr. Lee basically signed out. It was a Friday afternoon. Someone in his medical group was managing the group's hospitalized patients. That doctor saw the patient. He signed the discharge notice. He initiated breathing treatment. that he signed as I mentioned, he is the one who signed the discharge note. And the patient's wife testified at the hearing that it wasn't Dr. Lee who ultimately discussed the patient's discharge, but instead it was another doctor. So, if nothing else, I think those are important mitigating facts with respect to this patient. I think it also should be noted that this patient had a number of hospitalizations during that period of time. He was very ill. He was sent home and he was readmitted. I think it was about a week later with urinary tract infection. And then he had subsequent admissions after that. Now, with respect to the medical record keeping, what the major problem here is that we have a number of hospital discharges. And again, I mentioned the patient was hospitalized repeatedly. It was a very complicated patient case. And Dr. Lee's hospital discharge summaries, and I think also a dictated history and physical, came in a bit late. I think they came in at about 4 to 6 weeks. There wasn't a lot of testimony at the hearing with respect to what the standard of care requires for hospital discharge notes, whether it's a week, whether it's 10 days, whether it's a month, whether it's 2 months. There was some variation on that. Dr. Char, who was Dr. Lee's expert, said that the hospital that he works at, the UC Hospital in San Diego, there's considerable leeway when it comes to when you dictate discharge notes. And one of the board's members differed. They felt that these discharge summaries and history and physicals should have been done sooner. So there's a problem with respect to the timeliness of them. And there were also findings that these dictations could have been more complete and could have been more accurate. And I think one needs to consider here what happened is the board's expert was a hospitalist who had not done outpatient medicine for quite a while. He went through hundreds and hundreds of hospital records and found problems, as one would expect one would find when you're looking at that volume of material, problems in some inaccuracies, some notes that were not being done as quickly as they should have been. So essentially we have a different standard of care, I think, with respect to a hospitalist and a internist. The other thing is that Dr. Lee was not only the patient's internist, his primary care doctor, but he also seen the patient in the hospital. So there's a question as to whether the information needs to be as complete for someone in that circumstance as it would need to be for a hospitalist. And remember, the hospitalist is someone who basically takes over the patient's care at the hospital, and it's required that their summaries and the information that they provide be very complete, because the patient's primary care doctor probably wouldn't have had much to do with the hospitalization at all, except admitting the patient. So we basically have a situation here where Dr. Lee is not doing hospital medicine anymore. He has sort of gone along with the hospitalist movement, where many primary care doctors leave that up to the hospitalist. So I don't know what public purpose would really be served by imposing discipline on the basis of his hospital dictations not meeting the standard of care. A hospitalist would be something that he wouldn't be doing anymore anyway. And with respect to the decision, obviously with all these findings that have been stricken, all the serious ones, the dishonesty, the fraudulent alteration, the decision will have to be substantially rewritten to reflect Judge Kinney's ruling. But also there's something troubling about the decision as well, which I noticed in my written argument, and that is that Judge Cavasola made some very derogatory findings with respect to Dr. Suraja Char. basically saying he was acting as an advocate, he was evasive, and she was zeroing in on Dr. Richard's testimony with respect to Dr. Lee's alteration, or his addendum to this note. And what happened is when that case went in front of Judge Kinney, he basically agreed with Dr. Richard. So at this point in time, I think it would be an opportunity for the board to go back, look at the findings with respect to Dr. Richard, and substantially revise those. Also, with respect to the discipline, Dr. Lee has been on probation for 17 months already. He was ordered to take a medical record keeping course and an ethics course, both of which he's completed. And during this period of time, his last 17 months, he's sort of been branded, with this scarlet letter, for lack of a better word, as a dishonest physician who fraudulently changes his medical record. So this has had a very big effect on Dr. Lee and also on his practice. So what should be done with respect to the penalty here? I think probably the best way to resolve it would be to give Dr. Lee credit for the 17 months that he has already served, that he is already satisfied with respect to his probation. Another alternative would be to have a decision which imposes a public letter of reprimand and that he take the medical records keeping course, which he's already satisfied. And as to how this dovetails with the subsequent stipulation, that calls for a probationary period of 6 years. So if one were to keep this in place as a probationary order, it would seem that a fair resolution would be to credit him with these 17 months towards the 6 years of the subsequent stipulation. Those are probably my thoughts at the time.
Thank you, Mr. Lee.
Thank you.
I'm sorry, Mr. Jones, have I Dr. Lee, please.
There are certain facts here that are not in dispute. The case has been remanded. The Superior Court has made some findings. The case that existed going into the Superior Court is not what came out, as was pointed out by counsel. Certain of the allegations, certain of the findings of the board were not upheld. Certain of the findings were upheld. The ones that were upheld include, as was indicated, the finding of negligence with regard to discharge of the patient from the hospital. In connection with that, the Superior Court basically said the weight of the evidence supported the board's finding. And it noted that Dr. Lee's contention that the order was somehow preparatory or conditional was not supported on the face of the order, which simply stated that the patient was to be discharged totally without any other conditions than oxygen. There was nothing in the order, according to the court, that stated or suggested that the discharge was to occur later, or that another doctor was supposed to see the patient before discharge. So basically, the court focused on what Dr. Lee did, what the respondent did, and found the board's finding that his conduct represented departure from standard of care was upheld. So that finding of negligence, coupled with the other findings of negligence which were upheld, which related to record keeping, provides constitutes repeated negligent acts and is a basis for discipline. So the board at this juncture has the jurisdiction to discipline Dr. Lee as it deems appropriate for the conduct. With regard to the record-keeping violations that were found, there were instances where the admission, history, physical, and then the discharge, were not dictated until roughly 2 months later. That was found to be a departure from the standard of care. The court, Superior Court, noted that complainants experts and board's experts persuasively testified as to the importance of timely, complete, and accurate records, and that the petitioner, Dr. Lee, was deficient in those areas. So you have two bases then for imposing discipline: the premature discharge order and then the failure to timely dictate medical records. I would submit that those do require, at a minimum, a record-keeping course requirement. The board also ordered additional education CMEs for 40 hours per year. I would recommend, or would argue that that also would be an appropriate remedy here. Take an additional CME that relate to dealing with patients of the nature that Dr. Lee dealt with in patient JM would be beneficial to his practice. So those two items would be the type of thing that is appropriate to remedy professional conduct engaged in. Similarly, and further, putting the doctor on probation in response to the court's remand, I think, is also appropriate. It would permit Dr. Lee to continue to take further educational courses and relate to the issues raised in this case. So going forward from this point, I think it would be appropriate for the board to enter an order for the period of probation, which I would recommend 3 years, down from the 5 years originally ordered. With respect to this case, it would not be appropriate this time to continue with the ethics course requirement. I think that should be eliminated with respect to this case. And so you would have to put forward a decision on this case for 3 years probation, medical record keeping course, and continued medical education requirements. There's the potential that this case may go back to the Superior Court for seeking review to determine whether this is an appropriate resolution. So this case, I think, should be maintained separately from the other case in which the board has, by way of stipulation, put him on probation. This case should be made separate because it may go again before the Superior Court for further review, and it would complicate things if it were somehow enmeshed in the other case that the board has issued an order on. So to summarize, I believe the board has the jurisdiction here and the basis to lower the probation period to 3 years from 5, to eliminate the ethics course for this case, and to require the medical record keeping course and the continuing medical education course.
Thank you. Mr. Stackpole?
I'll keep it quick because there's really not a whole lot more to say. I didn't mention the 40 hours CME. I probably should have, but I did slip my mind. But one needs to remember that Dr. Lee has been on probation already for 17 months, and one has to assume that he has complied with the terms and conditions of it, and that would include the 40 hours of additional CME. So he's done a lot of that already. Also, with respect to the medical record keeping course, it was ordered that he register for that within 60 days and complete within 6 months. And so that's something that has been satisfied as well. The ethics course, unfortunately, he had to take to comply with the order, but it would seem inappropriate based on, in retrospect, based on the findings of Judge Kinney. I think we do. There is some merit to the argument that the Superior Court still has jurisdiction over this and that it's been remanded, and that it would be cleaner, for lack of a better word, for the Superior Court to deal with the case if this case is kept separate from the subsequent case. But again, the overriding issue here is also fairness, and months that he's already served into the subsequent stipulation of order. Reducing the penalty from 5 years to 3 years, I think would be inappropriate and would constitute an abuse of discretion given the magnitude of the findings that were not sustained by the Superior Court. I mean, those are the sort of findings that I'm sure the board would agree are ones that usually prompt a stiffer penalty, especially findings of fraudulent alteration of records and dishonesty. And if you look at the guidelines, those are the ones that seem to put these penalties over the top. With those gone, and with the quality of care findings with respect to the HIP case also gone, it would seem to me that a more appropriate penalty would not be reducing the case from probationary period from 5 years to 3 years, but instead a PLR with no probationary terms at all, or basically a time served 17 months is certainly enough. I mean, after all, a physician can petition for reconsideration after 2 years for a probationary period, it's 36 months or not. So why then shouldn't the 17 months be sufficient to set, and also taking the medical record keeping course and taking what he's going to see me, what he's already taken, be sufficient in a case where there's very little left with respect to adverse findings now compared to what there was prior to the case going to the Sacramento Superior Court. And that's
Thank you.
that's my take on how the penalty should come out. I appreciate any questions.
Clarification based upon your statement, so there was no stay in place while you went to Superior Court.
Good point. I mentioned that in my brief. There was not. We applied for, we asked for stay, and Judge Kenney denied it, so we had to wait for a long time to have the case on calendar because the court in Sacramento was very impacted.
What terms and conditions of the probation original order did your client comply with?
He complied with the additional CME. He took the medical records keeping course, and he took the ethics course.
Mr. Jones?
I would suggest that your last series of questions soliciting evidence that's outside of the record, I think it's it's proper to assume.
You made an argument about it, so I just didn't know what the position was.
Sure. I think it's proper to assume that the order's in place and they presumably complied with it. That an order going forward from this point can nonetheless include a medical record keeping course. Usual language has included permission to substitute in a prior course taken. So the fact that you've already taken would fulfill the order and go forward from here. Similarly, with regard to an order going forward that eliminates the ethics course, that would be reflective of the fact that in this case, the Superior Court took out the issues that would have supported the ethics course. With regard to the continuous CME, I think that's the remains something that is appropriate and would be educational and beneficial to public protection for that to be in a short period of time. It's 3 years as I hear. If there's a question,
Thank you. Again, caution the panel that you can solicit, you cannot solicit new information, just clarification of evidence already. I'll start with that. There you go. Okay, with that, thank you for your presentation. We're off the record. We'll go into closed session, and I ask everyone to please leave the room.